All right, good afternoon, everyone. I hope everyone had a good lunch. This is the Introduction to Concussion Vision Evaluation and Rehab workshop, so just to make sure you're in the right room. If you were hoping to join our strength training program, it's going to be at the hall. So it's my pleasure to introduce our speaker for today. Our speaker is Dr. Jeremy Schumacher. He received his doctorate of optometry degree from UC Berkeley School of Optometry. Since graduating, he has remained connected to the school, working in the Clinical Research Center and as an assistant clinical professor. He specializes in vision therapy for learning-related vision problems, sports vision performance training, and concussion rehab. As chief of sports vision at Cal, he mentors fourth-year optometry interns and serves patients referred from UCSF, Benioff Children's Hospital, Stanford, and other professional and youth teams. Joining him today is Brianne Walters. Brianne is one of our physician assistants here at UCSF Benioff Children's Hospitals. Brianne went to PA school at Samuel Merritt. He joined our group in May of 2023. He is part of our Pediatric Orthopaedic department. He has special interest in sports injuries and neuromuscular conditions, and for this year has actually joined our team for organizing this course. So welcome to Dr. Schumacher.
Thank you very much. I'm pleased to be here, and I want to also thank my resident, Sam, for coming. He's going to help us on the demo as well. I could talk for 2 hours on vision stuff, and I suspect there's a lot to learn for you guys in the vision space. I do want time to be able to break out and do the demonstration of the VOMs, but just a show of hands of who's familiar with VOMs on the outset, just so I have an idea.
You can take that out.
Okay. So who's familiar with VOMs? Raise your hand. Great. So a lot of people will be learning it for the first time, which is cool. It's not that big a deal. I had just a couple of disclosures. I'm advising a couple of software startups in the vision training space and the electronic health record space for optometry. Did you guys know it was World Optometry Day? I didn't either, but it popped up in my inbox, and now you know. So happy World Optometry Day. So just to frame this discussion, when we're talking about post-concussion assessments and vision rehab, I think of it as hardware and software updates and upgrades. You know, we do a comprehensive eye exam like you might get to get your glasses and everything. We do special oculomotor and sensor motor testing. We do a refraction to test whether glasses or contacts might be valuable. And really, you know, the physical eye itself is like 5% of what's going on, and the brain is everything else. And so everything I deal with is brain, neural tissue, right? So if we're nudging on things, that's a lot of where the healing and benefit comes from. I'm going to skip ahead some slides because we don't have a lot of time, but I just want to lay the foundation. There's a high prevalence of dynamic vision problems in the general population. There's a huge diversity of visual abilities across the population. No concussion or concussion, whatever it is. Very common are accommodative or focusing disorders. That's the lens inside the eye and the muscle that controls it. There's a lot of people, about 10% of children, age 6 to 18. Some studies have shown 10, 20, even 30%. I can tell you it's a high proportion of kids and adults, and it's a very high proportion of people who have had concussion. Convergence insufficiency, that's an inability to aim the eyes inward and keep a single clear image. That's at least 5% of the population, but there's studies that report up to 33%. And hyperopia, I'm putting in this dynamic vision problem category, which is 31% of adults in the world and lots of kids too. Hyperopia being a condition where you're going to pass the eye chart in many cases. So if you do your vision screen and you say, oh, they see 20/20, job well done. you're not capturing these people. And these are the people that tend to suffer the most after a brain injury. Because hyperopia means that the eye is too short, so optically speaking, light doesn't come to a clean focus. However, we've got that dynamic focusing element with the eye, the lens, that accommodates, and so you can see the 20/20 in the eye chart, no problem. Maybe some problems sometimes, maybe when they're tired it's a little bit less, but they'll still pass. Up close, where we all have to focus harder, it's a lot of more work. And it's a condition of fatigue of the visual system. It really drains that brain and those eyes over the course of the day, and especially after a concussion. Vision diagnoses are very common after concussion in adolescents. This was a study published in 2015. Cross-sectional study of 100 adolescents, age 11 to 17. It was at the Minds Matter Concussion Center in Philadelphia. And they found a 69% incidence of at least one vision diagnosis, including accommodative disorders, 51%, convergence insufficiency, 49%. And really those two go hand in hand together. When we focus more up close, our eyes have to converge to keep that single clear image. So that's kind of where those numbers show up about the same. Saccadic dysfunction, 29%, and multiple diagnoses, close to half, right? These are some common visual symptoms post-concussion. Yeah, there's blur, intermittent blur, frontal headaches. So if you have someone complaining about headaches around the eyes or centered on the forehead, that's a high yield for eye stuff, okay? Light sensitivity, of course, sensitivity to motion, visual motion, ghosted or shadowed vision, not necessarily double vision, but there's just like this extra little ring or fringe to things that they're looking at, words on the page, etc. Eye strain, rapid eye fatigue. So it's not a condition of like maybe everything is fine, they can see clearly, but their eyes tire out rapidly when they're on a device or when they're trying to read a book. Dry eyes is ubiquitous among our pediatric population and our adult population, for sure. And that adds another layer of complication to their symptomatology and their vision. Words might move or swim on the page, and of course, double vision. I just wanted to share with you a couple of screening symptom surveys that we use in the vision space. And these are actually helpful tools if you just have them as printouts and hand them to a patient in the waiting room. If you have, or you examine them, you hear some visual stuff, a little vague, have them and the parent fill it out, can be really helpful as a screening tool too. The first one is called the Convergence Insufficiency Symptom Survey. It was developed several years ago, and it's been in multiple studies now, validated and reliable. It's 15 symptoms of dynamic visual skills problems affecting near work. So, blur, tired eyes, double vision type questions. And the points are totaled up. And if you score a 16 or higher, it's suggestive that there's a vision problem, highly suggestive, and 21 or higher for adults. Now, this doesn't, if you score 5 points, does that mean you don't have convergence insufficiency? No, it's very highly suggestive if you score over that threshold. And it's great for baselining and monitoring symptom improvement. Another one that was developed later is called the Brain Injury Visual Symptom Survey, more relevant to the concussion space. It is a lot more in depth. So there's 8 major categories of visual sequelae, including light sensitivity, dry eyes, peripheral vision, depth perception that aren't included on that 16 or 15 question questionnaire. And symptoms are rated on a scale of 0 to 4, never to always. By the way, anytime you want to stop me and you can ask questions. I'm happy to answer, okay? So again, our examination, extensive case history, symptom screening, visual acuities, of course. Can they see clearly at far? Can they see clearly at near? What are each individual eye seeing? We do a cover-uncover test to look at the eye alignment or pressures for the eyes to deviate from where they're supposed to be, which are very common and provide a foundation for contributing to symptoms, blur, tired eyes, etc. A lot of ocular testing, so tracking, accommodation divergences, VOR. The developmental eye movement test, if you guys aren't familiar, is very similar to the King-Devick, which you may have heard of before, but it's a cool little test that take very short, standardized. It actually has norms for pediatric population, which is great. And they read vertical columns of numbers, a couple pages worth, that aren't really demanding on the oculomotor system as much. And there's not a spatial demand. And then the last one is oriented left to right, like reading words on a page, same number of numbers. And you could get this breakout of whether, it might be slower because the tracking is more difficult, might be slower because the visual crowding on that last part. And I've seen in concussion cases, just the vertical slow down too, which is, I use to highlight with patients and parents too. If you're not familiar, the cover and cover test looks at strabismus. So are both eyes aimed at the target properly? Because a lot of strabismus involves little tiny deviations that you might not pick up by seeing someone looking at them directly. And then we pick up on a lot more pressures, I would say, on the visual system. These are called phorias, where the eyes might want to press out, pull out, and the brain is doing, and the eyes are doing the work to bring the eyes to aim properly, but there's a lot of extra work in the system all day long. Same thing for inward, and there's even vertical misalignments. And of course, there's muscle palsies, often can occur after a concussion, and those contribute to these deviations or pressures. And you might not be seeing a strabismus, but there might be this underlying pressure for the eyes to deviate vertically, which is really causing symptoms for a patient. Good. Ocular motility, so fixation, pursuit, saccades. We have inexpensive, quick, and standardized normed eye tracking and processing assessments. I like the DEM over the King Deathcote because of the norms for peds. And there's more expensive objective eye trackers that are out there too. In my private practice, I use a device called a realizer, which actually is normed and standardized and has you reading grade appropriate reading passages. And you can actually look at how the eyes are moving from word to word and how it's breaking down from line to line. And it can be very powerful in picking up on these little deficiencies in the visual skills. So we examine pursuits, which is that smooth following reflex of the eyes in all directions, following target left and right. Were the movements smooth or were they broken up, jerky, right? Nystagmus. And was their head movement? So we look at, are they compensating with their head as opposed to using their eyes? Are they compensating with their eyebrows? Their mouth, motor overflow. Saccades, so reflexively jumping from target to target, back and forth. Should be a nice, quick, accurate response. And sometimes it's not always like that. Sometimes they have to do a little corrective eye movement. They undershoot the target, or they overshoot the target, and we pick up on those kinds of things. Vergences. If you think about it, it is a tremendous trick we pull off to have single clear vision. We have two eyes, right? So you have to think to yourself, why am I not seeing double all the time? Right? The brain is pulling this off and pulling the images together, fusing them, producing clarity among lots of different distances, right? And while your eyes are moving dynamically. But that's where all the opportunities for that system breakdown occur, right? That brain control these motor functions of the eyes. So this is a very common area where we have some struggles. So there's just a raw reflex to be able to cross your eyes together. Can you maintain single vision, right? But there's constant alignment, realignment happening, looking near to far, 3 feet to 4 feet, little adjustments for you to see single and clear vision. And it can fatigue, so it might be solid in the morning, it might break down towards the end of the day, and other things will influence how you're maintaining that single vision. Accommodation, to me, this is the heart of a lot of our patients' problems. I don't know if Sam agrees. And it's hard to test properly, which is part of the issue. So accommodation, meaning that eye's ability to focus at things dynamically. We need more power to keep things clear up close than we do far away. And it's a dynamic process. We're constantly adjusting. And so we have this concept of overall power we're getting out of the eyes, right? And that is actually age normed. So since you were 3, you were an amazing focuser and you lost it year to year to year to year. And guess what happens when we're in our 40s for most people? Well, I'm still in denial, so I have long arms, so I can hold things pretty far away. But I'm noticing it messing with me. And so we can compare someone's performance. I have an 8-year-old come into the clinic. I know where they should be. I have a ruler to measure. I know where they should be for their age. And I know it should be consistent. And then so I can measure that. And even if they're a little bit of a distance off, that can be dysfunction because it exponential increase in demand on the eyes as we approach the eye. A lot more power is needed. Accuracy of accommodation, right? Can that brain lock in and ensure that clear images for both eyes? Facility of accommodation, which is that flexibility of the muscle to relax, focus. And that stamina, that maintenance of ability throughout the day. Think of all the things that you're doing with your eyes all day long. Think about the kids now, screens all the time, locked in focus. So we do a test called near point of accommodation test, and we do it one eye at a time, and we test multiple times as the key to pick up on fatigue and change. And we use a ruler because for a kid especially, it could be literally a few centimeters difference between normal and abnormal. So that it is a hard test to do in just a screening setting, so we don't include that. And when we teach you the VOMs, we're going to teach you the convergence test, which does also include accommodation, so you kind of get both in there at once, and that's better as a screening tool, I think. Any questions thus far? Yeah, so think of phoria as your brain is setting this balance, of muscles around your eye. You have 6 muscles that have to be coordinated. And for various reasons, developmentally or just how you're wired or an injury, the eye deviates from straight ahead or where it should be, right? And so aphoria is present. It's like this pressure present to push the eyes away from where they should be. And the brain and the eyes are overcoming that throughout the day. But you can see how that would be a factor in symptoms and blur and doubling and that kind of thing. So it's something we really need to be careful about assessing and dealing with in different ways. So VOMS, it's a vision screening tool that aids in the diagnosis of concussion and its management. It consists of a lot of the things we talked about. So smooth following eye movements, saccades, those fast jumping eye movements, vestibular ocular reflex, so your brain's response to your head or body moving to move the eyes to keep on a target that's somewhere else, right? Convergence, that ability to cross those eyes together and maintain single clear vision. And then visual motion sensitivity, which is your brain has to process this motion in a dynamic sport or a dynamic environment. And often that is overwhelming for someone who's had a concussion. It's just not able to filter that out as much. Why is it valuable? Well, let's skip ahead. So it's very useful clinically because it's got both objective and subjective elements layered in together. That makes it powerful. It takes less than 5 minutes. You don't have to do it perfectly to pick up on what you need either. So I think you guys get a handout of how VOMS is described in the literature, but I don't really do that to the T clinically. I don't need to do it that way. So I want you guys to feel like you have the flexibility to do what you need to do to screen, but it doesn't need to be perfect. And it's highly relevant to the patient's functional vision in the real world. So I had recent firsthand experience with VOMS. My 12-year-old son last spring was playing multiple sports, soccer, baseball, swim team, water polo. Cindy's lecture kind of hit home a little bit. He got nailed in the head. Guess the sport? No, swim team. He was doing circle swim, and then this girl in his lane kicked him right in the head. So he initially complained of a moderate headache, seemed to linger for a couple of days. Still didn't register to any of it. I'm keenly aware of all the things, and my wife is too. We didn't really register it as concussion. Then we went out for burgers, and I noticed he seemed a little overwhelmed in the restaurant. And I was like, oh, wait a second. I did VOMs there. I just was curious, and he didn't have any objective deficiencies. His movements and VR was good, etc. But he got a 3 out of 10 nausea with the pursuits and VR tests. So I'm checking time. I have a case I can go through too. That might be nice. I'm thinking if we have like 25 minutes or 20 minutes even for the demo, that should be enough. You guys good with me continuing to talk? Okay. So this is a recent case. 11-year-old Asian male, enjoys reading, climbing, running. 2 months prior, he tripped while running, hit his head, then got kneed in the head by another kid, and had more contact afterwards. He was referred by UCSF, Benioff Children's Hospital Sports Medicine Department. He was resistant to the eye exercises the PT had given them because they hurt his eyes. Does that sound familiar at all? He was taking melatonin for sleep, otherwise healthy. So he complained about distance blur after reading. He was a big reader before concussion, but can now only really dig in for about 20 minutes before he doesn't want to do it anymore. Mom and dad noted his left eye occasionally looked like it would drift inward when he was tired. That sounded familiar? That phoria, and then the brain and eyes have to overcome it, and then when they're too tired, start to lose it, yeah? He scored 0 on that symptom questionnaire. And that's some kids for you, right? Also some adults too. Clinical findings, unaided distance visual acuity was reduced actually. So his right eye needed the 20/20 letter to be actually 3 times the size to be able to see it properly, so 20/60 vision. Left eye was even greater, reduced 2100. Cover test, I found no strabismus, but I saw this latent pressure for the eyes to deviate inward. Okay, it's called an anesophoria. At near, it became even greater, 10. Okay, so I could see why mom and dad might notice when he's really tired that eye actually looks like it's misaimed, and it is misaimed, I'm sure, in that situation. Accommodation, so his right eye fatigued after several push-ups. It was normal initially, and the left eye started out a little bit outside the normal range and stayed there. We do a retinoscopy, so an objective look at myopia, astigmatism, hyperopia. He looked a little bit myopic to me, a little nearsighted. I knew better though. I knew he was faking me out. Objectively normal pursuits and saccades, but symptomatic for frontal headache, dizziness, and nausea after performing them. Near point of convergence, part of the VOMs. Initially, 16 centimeters was where he reported double, and I actually saw the eye kind of flick out a little bit. And he was able to crunch it in to about 7 centimeters. Normal would be 5 centimeters from the eyes consistently. And there's a little gray area, 8 centimeters is borderline, and beyond that, definitely abnormal. So I was on to him a little bit. I knew he wasn't really myopic, myopia being blurry distance vision, right? Because there's a new complaint, and I saw the pattern of other things happening where I thought the focusing system was involved, right? And he had a condition called pseudomyopia. It's a fake out. And when I dilated him, I used some special drops to relax the focusing muscles completely. So then we get this true sense of what are the optics of the eye, and he ended up being the opposite, hyperopia, right? The one I was talking about before, a little bit hyperopia, meaning his eyes have to work harder all the time to make vision clear, and that's not really helpful when you have a concussion, right? Because you're less efficient at doing that job. And eye health was normal. I didn't see any dry eye. So these were his final diagnoses. So why would he have the poor response to the initial treatment? Well, he was given thumb tracking exercises, right? Part of your standard PT set of exercises. it made him very uncomfortable because of the proximity, right? Because what else is he doing when he's looking at his thumb? He's converging his eyes and he's focusing more, right? And that induced that pattern of his eyes pulling together excessively. And it was this vicious cycle. Focusing insufficiency leads to the spasm of the focusing muscles, which leads to my distance vision is blurry. And it was all kind of coming together like that. So treatment goals, set goals. We want to reduce visual symptoms. Want to improve his tracking, his VOR, his near focusing, and overall visual stamina is a part of any program for anybody I see. Concussion, learning related vision problem, an athlete trying to improve their visual performance for their sport. And functional goals, wanted to be able to read longer without frustration and return to his physical activities. So I managed him with low plus glasses prescription for the hyperopia initially. And it doesn't need to be a permanent thing, glasses, but it can be. That condition is not going to go away, but maybe functionally the brain is able to handle it and deal with it more. So that's a conversation with the patient, and depends on their age and priorities and all that. I assign monocular push-ups, so one-eye push-ups to strain and stress that focusing reflex and build that power and flexibility and stamina. And gradually reintroduce the thumb tracking and VOR type exercises. Once the focusing system was able to handle things better, then that wasn't as discomforting. So what is active oculomotor rehab? Well, it's in-office training and daily home practice. Probably sounds familiar to the PT world and athletic training world. You must be mindful of the special population, of course, and there's a huge variation in the course of healing, I found, and it's very individual. We typically would do 45-minute office visits and can be as frequent as weekly, depending on the patient's individual situation. Any other questions? Treatment response. Next 2-week follow-up, 5 weeks post-eval, good consistent practice at home, excellent visual clarity and visual skills when I reassessed. Wasn't showing the reduced distance vision anymore. Then I graduated and gave him maintenance exercises. So do a couple things a couple times a week, and then glasses for prolonged near work, and then have a normal comprehensive eye exam in about a year. These are just some videos of some of the tools. Would you care to see? This is my son doing a rotating pegboard exercise.
This rotating pegboard?
So he's on a balance board right now, and he's got to put these little pegs on a rotating disc in a pattern that we've picked out.
Those little pegs, one by one, in the red square.
And we can level this challenge by increasing the speed,
Are you ready?
no balance or balance,
Let's go.
clockwise, counterclockwise. And it's kind of fun too. But I would tighter this out depending on how symptomatic they get, right? There's a lot going on. And so we kind of level the challenge appropriately and not push them in too many symptoms initially.
All right.
These glasses he's wearing are called strobe goggles. We use them for sports vision training a lot. They rapidly flash or block your vision several times a second, and we can vary the level of the blocking. So it's great for training reaction time and eye-hand coordination. But I also use it in rehab to increase the visual challenge. And so they again,
Andrew's going to continue.
try and do the same thing. You can see how his balance is more
Glasses
challenged
that block his vision several times a second.
when he's doing it. You can see those goggles flashing a bit. Now, I wouldn't do this with every concussion patient I have. But they will probably get to the point where I can do this kind of stuff with them. This is my daughter using a Marsden ball, another simple, easy tool. It's got randomized letters, sometimes different size letters scattered throughout the baseball. And we can use it for a tracking and scanning task. Find the letter A, where is it? Dynamic, because you can move around the ball. And then we can use it for a near far task. So I can have another chart, like a heart chart, if you've heard of those before, and look at the first letter on the heart chart. It's an A. I got to find an A in the ball. And we're going back and forth, converge, diverge, focus, not focus, right? And we use that all the time in clinic. This is another little tool
And they all
called
want
it Trace the Eights. So she's on a balance board doing it. You have to roll a little marble on a track
falling
and
off.
keep it without falling off. And it's also a really good challenge. Looks fun, right?
And they all want you to
And then we have touchscreen devices and lots of amazing softwares we can use in the clinic and at home that challenge the brain in more developed ways, add cognitive loading, that kind of thing. So this is a flash memory task. She's presented with some words in a certain order and she has to find them quickly in the proper order after presentation. So there's a lot of things going on in this exercise at once. And I use this with a lot of my concussion rehab patients. And same rotating concept, but now we add a layer of cognitive loading. So he has to sequence the alphabet and find them on the rotating disc on a balance board as well. Right, so you have to remember your alphabet, and then if that's too easy, then make him go backwards. Fun, right? So a couple more slides. Special considerations you guys should be thinking of because you probably suffer from this too. Dry eyes. High proportion of society has dry eyes, full stop. And that includes children. Dry eyes often do not present as feeling dry. Common symptomatology includes tired eyes, feeling that your vision is inconsistently clear. You have to blink more to get your vision clear. Light sensitivity is part of that too. And common mechanisms include screen use because there's diminished blink rate and quality of your blinks. Meibomian gland dysfunction, which is these oil glands that line our eyelids. They're supposed to be providing a slow trickle of this olive oil type oil to your tears, which forms a base layer to prevent evaporation. And guess what? It's breaking down in everyone these days. So we see a lot of this, right? Then after concussion, there is autonomic dysfunction, right? Well, how do you produce tears? It's your autonomic nervous system. And there's less tear production, I'm sure, in many of these patients too. And the vast majority of my post-concussion syndrome patients I've worked with have dry eyes as a layer in there. So our first line treatment is not eye drops. You can prescribe eye drops, but they don't really deal with underlying problem. We prescribe warm compressing with special masks you can order online. They heat up in the microwave or plug in that really have to heat the eyelids to a consistent temperature for at least 10 to 15 minutes to actually get that oil to be more melty within the eyelids. You have to do it consistently, so it's a new habit. That's how it works best. Breaks from screens, non-preserved tears, gel drops or ointments for coverage at night, reducing other sources of inflammation, right, allergies, etc. And there's other newer treatments for dry eyes that are available too. Light sensitivity, we hear and see a lot in our clinic. I'm sure you guys hear it a lot too. Incredibly common. Patients adapt to their environment to how they're feeling. So they'll cocoon, they'll reduce the brightness on their screen. And a lot of our treatment involves taking them out of those behaviors because doing that stuff makes you dark adapt, which makes your light sensitivity worse. So you actually have to expose yourself in increments to be able to build back to normal tolerance of light. And so we use dry eye treatment. Just training the oculomotor system that's deficient will make your light sensitivity better. And we use tints that cut out the blue, most annoying spectrum of light out of the system, and that can help too. And we gradually reacclimate and build that tolerance to normal levels of light on screens in the world. So where to refer? Ideally, send to an optometrist trained in the assessment and management of the visual consequences of concussion. These ODs may identify as neuro-optometrists, pediatric and development optometrists, etc. There's good resources found on the Neuro-Optometric Rehabilitation Association website. Or you can send them to Cal. Any vision-linked symptom that lingers beyond 2 weeks is a good referral. Multiple concussions in the history of post-concussion vision problems, of course, too. Many youth, maybe the majority, and many adults have never had a comprehensive eye exam. It's recommended yearly anyway. So you're not going to do anyone harm by getting them an eye exam because you see these lots of little easy opportunities to help them, even if it's just glasses temporarily or whatever. Untrajected refractive errors, hyperopia in particular, are a common contributor of the visual symptoms post-concussion and need to be seen by an eye doctor for a prescription. Cool. Any other questions before we do the hands-on stuff?
A little bit about the observational findings you might see in someone who has aphoria. Is there like a head tilt or not that?
You might see head tilts for compensation, especially if they have like a superior oblique palsy, which is pretty common after concussions. So tilting one head to the side or the other, or turning their head this way or that, like in a lateral rectus palsy. But most of the time, you're not going to have that. So you're not, as a screening kind of physician, you're not going to pick up on that. And we really need that alternating cover test to be able to detect those things if you know how to do that. Anyone else? So I think we should try to break out into groups of maybe 4 and kind of choose a partner, and we'll kind of walk around and take you through VOMs. So maybe we'll demo real quick too, and we'll have you guys do it. So we'll show you what's up. So who's my partner? Okay. So the first thing I would do, grab a target, pen light, popsicle stick with something on it, that kind of thing. You can just use my finger and you're just going to follow my target back and forth, and I do it several times. And I'm looking to see, are those eye movements smooth, or is there some breakdown or nystagmus, right? And it's important to do it at least 10 times. And if you got a person that's really motivated not to have a problem, but you think that maybe they do have a concussion, keep going. Keep going. 30 seconds or a minute, and they'll start to break down, and they might have their symptoms provoked. And then you do up and down, horizontal and vertical components, but important after.
Speak a little bit louder.
Yeah. What did you miss?
It was just.
Yeah. So you're looking at the breakdown of those eye movements. Are they smooth? Are they jumpy? And then you ask the subjective. So does it provoke any symptoms? And the VOMs includes 4 categories of symptoms: headache, dizziness, nausea, and fogginess on a 0 to 10 scale. And so even if you have no objective finding, it looks smooth. If it's provoking symptom, that's a hit. And so you do it horizontally, you also do it vertically. Keep your eye on my thumb. And we're looking for any breakdown in eye movement control. Verticals are harder, so you might see a little jumpiness depending on how fast you're going, and that can be kind of normal. But then, did that provoke any symptoms?
No.
Okay. So then maybe I'll have Sam do the next one with you so I can talk you through it. So do you want to do saccades?
So I'm just going to have you look between my 2 thumbs here as fast as you can.
So she's got 2 targets pretty far away, 1.5 feet, 2 feet, going back and forth, back and forth. We're looking for the accuracy of those saccades. So is it right on target? And she's great saccader here. No symptoms, and we'll go up and down. Undershoots.
Can I ask a question?
Yeah.
How long do you do those things?
I would do it at least 10 times back and forth. So a cycle will be there and back, or jump and a jump. But again, if you've got a patient that is highly motivated not to have a problem, and keep going, because you might see them start to fatigue, and their eye movements will break down. They may not fess up to being nauseous or dizzy or whatever, but they might fatigue. Yeah. VOR.
So I'm going to turn your head side to side while you're looking at my thumb.
A little bit quicker. And it doesn't have to be large range of motion. It can just be a rapid back and forth. And you'll see right away, a lot of them don't even want to go fast. They're guarding against that is going to get dizzy or wobbly, right? And you're looking objectively to see if the eye is moving and keeping on target. So you might see a breakdown of the fixation, but often you won't because it's pretty subtle sometimes. But then it often provokes symptoms. So that I would say more often than not, it provokes symptoms, the VOR. And then we do up and down.
And of course, you said headache, dizziness, nausea.
Fogginess. Yeah. It doesn't have to be limited to those. I mean, I think you guys should have the flexibility to use your own tools and common sense, and people will describe all kinds of other things too, right? So that's okay. If it provokes symptoms, that's not normal. Yeah. All right, and we'll do, yeah, NPC.
Just follow my finger towards your nose. Let me know.
I recommend having something better, like a little something on a pen or a pencil or some other target that they can lock onto rather than just a finger. And what are we looking for? You're going slow enough where you're going to try to observe both eyes simultaneously. You'll see one eye start to pull away from the target eventually, if that's where the breaking point is. Objectively, that's what it is. You ask the person in your chair to report if they see double. They're going to report to you it gets blurry. And you don't care about that. You only care about it, is it double? And you do it multiple times. And then you can ask if it provokes symptoms.
And you go all the way to touching their nose, or how close do you go?
You stop when you don't see them converging together anymore, or when they report double. And if it's all the way to the nose, then that's a pretty normal finding, actually. That's because it's like within 3 to 5 centimeters. But you do want to watch their eyes all the time because they won't tell you it's double most of the time. Does a kid even know what double vision is? I don't know. Probably not. So
What do you see with their eyes?
you'll see an outward shift of the non-dominant eye. So that's why you're gonna have a global sense of what their eyes are doing as you're pushing the target. You're not watching your target, you're watching their eyes the whole time. And then you'll see one eye go out. And maybe we should look at that too when you guys are practicing with each other, because that's a more subtle thing to pick up sometimes, especially they might have convergence insufficiency and they lose single vision way out here. Okay, they might forget to tell you, or brain might be suppressing it, and that's significant. But it's also very subtle to see the eye shift a little bit. It shifts less out here than it does in here. So that we can key in on that. And then the last component is the visual motion. So she's keeping eyes, head, body, upper body all in line. So target moves with the eyes, head, body. You're streaming the world behind your target. So that's the visual motion part, which can be very stimulating and provoking in patients. What you're looking for, though, is nystagmus, particularly at the endpoints when you're making that transition, because this is also called VOR cancellation. So your inner ear is telling your brain, hey, things are moving, move the eyes. And your brain is telling you to keep your eyes on the target, which is moving with you. So in a perfect world, there's no movement, right? They're canceling each other out. So you can pick up on like jump, jump, jump at those endpoints of the eyes. That's the objective. And then often it provokes symptoms too. Yeah.
So not every side of your eyes, so could I have them do like a smaller?
Yeah. Just do it like a 90 degree, one wall to the next. Yeah. I know it's described differently in the VOMs, but again, you can modify it.
If someone normally wears glasses, should this be done with or without the glasses?
With glasses. I mean, some of it's like, we would, as optometrists, assess, do they really need their glasses to see the target? But that would be harder for you guys to know or not. So probably better is if their habitual is when they're looking at things up close, they have glasses on, I would say have glasses on. Any other questions before we break out? Let's do it. Find a partner.